Welcome everybody to Mountain West AATC Echo. I am very excited about the session today. We are going to try something a little unique and new for the didactic portion. This is going to be the first in a series of pro-con debates. So I am very eager and interested to see everybody's response and hear from Dr. Danneretti and Dr. Harrington, who are good sports and agreed to do this. Then we will have two great cases with some complex resistance and ARV discussions, and we'll ask you all to get involved in that discussion. So without further ado, this is how this is going to go. I'm going to make a statement which I think has no clear right answer. I'm going to ask you all to weigh in on it. Then I've asked Dr. Danneretti to present the pro or agree side of the debate. Then Dr. Harrington will present the con or disagree side. Here we go. Here is the statement. Patients with HIV-associated cryptococcal meningitis in the United States should start ART within 2 weeks. So that would be within 2 weeks of crypto diagnosis and starting crypto therapy.
Yes, as my title slide says. Vote yes, as half of you did, and I hope to convince the other half to start treatment early. I just have a few slides, but what I wanted to start with is that this study came out in 2009, which really changed the way that we thought about starting antiretroviral therapy. We used to wait until we thought people were get better from their opportunistic infections, and then we realized what we were doing was wrong. And in fact, starting early does save lives. And this is the ACTG study, which was a multi-center study in the United States, looking at a number of opportunistic infections and starting within 2 weeks versus delayed start. And it had a number of opportunistic infections that included, but as you can see, this is the Kaplan-Meier survival curve, the people that are in the solid line who started early were alive more so than the people that started later. And here you can see broken down by type of OI, type of opportunistic infection, and cryptococcal disease is on here. One exclusion is TB, and we've talked about TB before, that has been studied, numerous studies about optimal timing. But when we look at cryptococcal disease, everything really favors early start. When we look at all comers, including cryptococcal disease, right there, in case you missed it. So what the upshot of this study is that early ART within 2 weeks resulted in less AIDS progression and death with no increase in adverse events or loss of virologic control compared to the deferred group. And there were, in the cryptococcal group, 13 patients who started early and 22 patients who deferred. There were no deaths in the early arm of patients who received ART early who had cryptococcal meningitis. So this is really important, and it's consistent with other OIs. Dr. Harrington will try to convince you that there is this study, the KOAT Trial, which he will call likely the definitive study. So I wanted to bring this up because this study did not take place in the United States. We're talking specifically in our ECHO community what we would do in a relatively resource-rich setting. So Uganda and South Africa are nowhere near the Northwest Mountain West AATC. So this study looked at early versus deferred treatment, and of the people who started, of the 88 people who started early, 45% died versus 30% or 27 in the deferred group. The majority of deaths are in the difference you see actually in mortality occurs between weeks 2 and 5 of treatment. So what does that mean in terms of numbers? So when we take out the other groups, other patients, 21% died who received early treatment versus 8. Now, what is treatment in this study? Is this treatment that we would give here? And that's what I want to highlight. No, it is not treatment that we would give here. They gave amphotericin, which is what we give, but they did not have access to 5-FC, which we know improves survival. And there has been a separate study published about this along with the KOAT trial in 2014. They also acknowledged themselves in this study that the deaths, we worry about cryptococcal iris. When they had blinded review of these cases, they were not able to say if it was iris or not. They could not define that, and they did not meet those definitions. They said it was related to cryptococcal disease itself. So again, I point out that they were not receiving treatment that we would give here in the United States. The study was also stopped early by the Data Monitoring and Safety Board because of these differences, which would overemphasize potentially the impact and the differences in these groups. Also, one other important aspect to note is that there was not a complete equity in the groups here at baseline, that there were a higher percentage of individuals who actually had elevated intracranial pressure at presentation in the early group, 58% versus 51% in the deferred group. And again, like I point out, there was no 5FC given with the amphotericin. And here is the data that was published by Jeremy Day's group from a Vietnamese study that showed that 5FC did lead to improved survival compared to AMPHO alone. When they looked at AMPHO plus fluconazole, which is what the KOAT trial did, there was no significant difference compared to AMPHO alone. So again, we provide superior therapy here and management of patients with cryptococcal meningitis and can do earlier treatment. When we looked at, even in the KOAT trial, they acknowledged that patients who do have CSF white counts greater than 5 cells, there was no difference in the early and the deferred group. So, what did the experts say? Not just me sitting here, not just Dr. Harrington, but what do the experts say? Well, CDC HIVMA guidelines are kind of wishy-washy. I think there's a lot of disagreement on the panel, essentially, and so optimal timing is controversial is what they point out, that maybe we could delay, but maybe starting after induction is fine. IAS USA panel, which includes friends of Mountain West AETC like Joel Gallant and Paul Sachs, are much more firm in their recommendations and for resource-rich settings with access to 5FC and intracranial pressure monitoring, it is preferred to start within 2 weeks of cryptococcal therapy. So, again, that is the argument for early start because we have the means to treat these patients effectively with medications that improve survival and that we know that patients do better with early start. So, there we go.
Thank you, Dr. Generati, for presenting that perspective, and we will slide the keyboard to Dr. Harrington for the disagree point of view.
Thank you very much. Okay, so cryptococcal meningitis and early antiretroviral therapy, clearly just a terrible, terrible idea. So here we are, that's right. Sharisha brought up the KOAT trial. And one thing to remind everybody about it is the KOAT trial was a prospective, randomized clinical trial. That is the gold standard for making clinical decisions. We talk about observational studies and that they inform hypotheses, but the hypotheses must be tested in prospective, randomized trials for us to make any sound decisions about therapy. So, just to review quickly, this was performed in Uganda and South Africa, but it's not like they were using water to treat the people at cryptococcal meningitis. They were using high doses of amphotericin, up to 1 mg per kg per day, with high doses of fluconazole. So perhaps not quite as excellent at sterilizing the CSF as if they had 5FC, but remember 5FC is also toxic, and in this case they had no toxicity from the AMPHO or the fluconazole. And they were randomized to antiretroviral therapy, a little different than what we would use, AZT3TC and efavirenz at early times at 6 days versus a month later. The hypothesis of the people that designed this study was that early therapy was going to be better. So there was already this bias that treating early was going to be better, but they had to stop the study, and they stopped it early because there was a mortality benefit. Not that they sterilized their CSF a little bit earlier or a little bit later. People died, and they died more frequently when they got started on antiretroviral therapy sooner. The groups were a little bit different. Sharisha's point is correct. The earlier group was sicker. They had higher opening pressures and higher antigen studies. But by the time they were randomized, and they were randomized, only a week into therapy, they were equal. They had the same opening pressures. They had the same number of people who had little CSF inflammation. So at the time that they got switched to therapy, to antiretroviral therapy or not, the groups were the same. Early therapy did not lead to more rapid clearance of crypto, and it did lead to more pleocytosis in those groups that had low numbers of white cells in their CSF at baseline. One thing that Shirisha brought up was that they said that there was a lot more iris in the patients that got ART early, but that's because the definition of iris was probably flawed in this study. It required that people got better on their anti-crypto therapy and then had a decline when starting antiretroviral therapy. So many of these people just never got better. They just got put on antiretroviral therapy and then they died. So if you relaxed your definition of an iris condition, probably a lot of those people that died with cryptomeningitis actually died from cryptomeningitis with iris. So I won't belabor this. This is the overall survival for the study. The dark line is the earlier treatment, and you can see that survival was down less than 60% in the group that was treated early, and that was concentrated in those people that had very few white cells in their CSF, so those individuals at greater risk of death and likely at greater risk of developing an iris syndrome. The other point that I want to make here, and I think this is maybe the strongest point of this study, is that there was never any benefit from starting therapy early. If you look at any of the subgroup analyses, even those people that had CD4 counts that were less than 50, the trial always showed a more favorable outcome in the group that was deferred. So I think the most that you can say, even if you discount this study, the most you can say is that starting therapy early might make you have as good an outcome as deferring therapy, but it never led to a better outcome than deferring therapy. So what's the rush? It's not like you're making people better by treating early. You're hoping that you're going to be as good as the people who decided to defer therapy. So if that wasn't enough, that's one prospective randomized study. This is another one done before the KOAT study in Zimbabwe. This time they used fluconazole, so Shirisha will try to criticize this, that this is not adequate therapy, it's not sterilizing the CSF, and that may be true. But all these patients had very low CD4 counts, and they too, if they had treatment early with antiretroviral therapy, and the antiretroviral therapy was not that potent, they still did much worse than the group that had deferred therapy. Then this study I just added, this was a longitudinal cohort of 130 patients in Durban who were started on amphotericin and then got put on antiretroviral therapy. They were looking at the incidence of iris syndrome, and they found that it was 25% of people with cryptococcal meningitis who were started on HAART at 18 days or so had an iris syndrome. And on multivariate analysis, that was associated with a persistent, anybody who had still a positive CSF culture was much more likely to have an iris syndrome. So if you start antiretroviral therapy early, before your anti-cryptococcal therapy has had a chance to sterilize the CSF, then you're more likely to develop an iris syndrome and have a poor outcome. I think we'll skip over this one and go right to the IAS guidelines. The IAS guidelines that Shirisha quoted used as a support for their recommendation to start early this one abstract that was presented at CROI 2 years ago. It's an interesting abstract, but it's the result of 3 retrospective cohorts. It's not a prospective study at all. And they did it to try and, quote, mimic the KOAT study because it's not as good as the KOAT study. And this abstract has also never been published. It's been almost 2 years and it's not in print. They found that there were equal numbers of deaths in those that did and did not start antiretroviral therapy early, so supporting Shirisha's contention. But the difference between the groups, they were started HAART less than 2 weeks or greater than 2 weeks, and they don't give any more detail than that. These individuals could have started antiretroviral therapy at 15 days versus 13 days. Essentially the same thing, and they don't give you any information about that. Also, it goes back to 1998 when ART therapy was not very effective, and so we don't really know about how effective early antiretroviral therapy was and whether there was less iris because there was poor antiretroviral therapy. So I think the conclusions are clearly don't start ART early into the treatment of cryptococcal meningitis. Wait a month. There's just no reason to start early. You're not making patients better. All you can hope is that you'll make them as good as if you deferred therapy. And early antiretroviral therapy is associated with more iris and is associated with higher death rates. And I'll leave the last point alone. So there we are.
Thank you, Dr. Harrington, for presenting the disagree side of this argument. Dr. Danneretti, any rebuttal statements?
Yes. So Dr. Harrington actually agreed with some of the comments and the limitations of that study, and he acknowledged that the KOAT trial, which is really what he's hanging his hat on for the data here, which again did not take place in the US, and he already discredited the subsequent studies that he presented because they were not randomized control trials like the ACTG study. And also, they had suboptimal therapy, which he also acknowledged. And so, again, really hanging your hat on one study, the KOAT trial, which has major limitations in that they did not receive optimal treatment, was not in a resource-rich setting where we can manage a lot of the potential complications of early treatment and intracranial pressure management. So again, and going back to my original study, which was a prospective randomized study, the ACTG study looking at early treatment, did show a benefit. So
let's go back. So let's go back to that early study, and the outcomes in that study were death or age-defining events. So not just death alone. And the number of people with cryptococcal meningitis was 30 or 40 compared to over 200 in both of the randomized prospective studies that I showed. So very small numbers of people with cryptococcal meningitis. Furthermore, in the KOAT study, they did a pretty good job managing people that had high intracranial pressure. The mean number of therapeutic LPs that they had for the people with crypto were 3. So they were working hard, they were paying attention to iris, they were doing everything that we would have done in this country. They didn't use 5-FC, but it's not like they were using nothing. They were using amphotericin and fluconazole, and they showed a clear mortality benefit for deferred therapy. So again, the point is, why would you start early if it might kill your patient? Why not just wait a month until there's less crypto around to respond to and have a better outcome?